the press after, is that medical mistrust among black males is about more than just Tuskegee. I mean, this seems obvious to this audience, but believe me, it was important for us to be able to demonstrate that. And we found that black men who had actually experienced a recent patient-centered transaction. So a transaction, you go into the doctor spends enough time with you. He looks you eye to eye, he shows empathy, respect, and warmth. Men who reported those common human experiences, guess what? We're less likely to have high levels of medical mistrust. So what that told us is that these things are fixable and we can intervene, modifiable. We can intervene on some of these factors, and we didn't need to just think about Tuskegee as a source of it. And then in fact, as one of the organizational psychologists that I really admire has said often, trust really thickens and thins as a process of cumulative interactions. Black men who reported more experiences with everyday racism, for example, in this study, were more likely to report more medical mistrust. And that might be why. Because if you experience discrimination in your everyday social environment, you're more likely to believe that the same discrimination that followed you as you tried to get a cab in New York City is going to follow you into the doctor's office. And in fact, studies have shown that doctors hold implicit biases about patients of black race. So it's not entirely improbable for black males to believe that if they've experienced discrimination elsewhere, that it will follow them into the healthcare setting. So that's what we found. So I want to talk a little bit about why this matters, because if you just know that medical mistrust is driven by these factors and then medical mistrust doesn't make a difference, then we can stop studying it. My work here is done. I can pack my toolkit up and my surveys and my team, and we can leave barbershops. But actually what we found when we did a study to see whether or not masculinity and medical mistrust made a difference on black men's use of healthcare services, we found that black men were overwhelmingly less likely to, or more likely to delay getting preventive screenings like cholesterol screenings, blood pressure screenings, and to get a routine health examination when they had higher levels of mistrust. And so this slide really just shows just a percentage of delays that we saw. As you can see, most of the delays were for those routine health examinations. And if you think about this, those are the gateway experiences for healthcare services. If you don't get a routine health checkup appointment and keep it and actually attend it, then you don't get a cholesterol screening, right? You don't get all of the other subsequent screenings that are necessary to detect disease early on. So it was really important for us to be able to see these patterns of delays and to understand them. And then when we looked at the data for whether or not, and this is just a bunch of odds ratios, which I'm going to summarize for you in just a second, the important thing to pay attention to here are the ones that are starred. So those are the ones where we found significant findings, and they're color-coded according to the examination. So the red bars are the routine health examinations, the blue are the blood pressure screenings, and the black are the cholesterol screenings. And as you can see, when we looked at all of these factors related to masculinity and we looked at medical mistrust, you see that the highest odds of delaying screenings were found for medical mistrust, above and beyond healthcare access or insurance, whether or not men had a usual source of care, whether or not they had a job. I mean, all of those things we held constant, and we still found a significant effect for medical mistrust. So it matters, and it's something that we have to begin to understand more of and try to intervene upon if we're really going to make a difference in getting black males into healthcare in a more timely fashion. So I want to, I'm going to skip past this, and I want to, how are we doing on time?
We have about 5 more minutes.
Okay. So one of the things I do want to talk about that we didn't get to, which is the other outcome that I'm interested in, is black male depressive symptomatology. And what I want to do is convince you a little bit that this is an area of inquiry, and hopefully increase the interest in this room and understanding more about factors that are associated with male depression in general, because it's a serious population health problem, but also to think about marginalized men in the scope of your work, and especially work around mental health. Because I always say that if you think the studies around healthcare use are slim, the studies around black male depression or depression among ethnic minority males in general is quite slim. So why do we care about male depression? Well, first of all, we know that there's this paradox in mental health that we're all trying to understand more about. Black men and men in general are diagnosed with depression less often than women, but they have higher rates of suicide completion. And these data persist across time. So it's not just we're looking at 1 year and we see this spike. And there's been some variation, as you can see from the trend slide, some years where we've gone down a bit and others when we've gone back up. But in general, death rates for suicide among men are higher. Women are more attempters, or higher attempters, men are completers. And one of the reasons why is because men tend to use more lethal suicide means. When men want to commit suicide, they use guns. And when women want to, they use pills or other sort of less direct means of committing suicide. So there is a reason to understand what's driving depression, because if men are suffering in silence, then we need to understand what their suffering is about, and then how we might be able to intervene upon it. One of the issues, the reasons why this is really important among Black males, is because we saw this dramatic increase in suicide rates among younger Black males between a particular period. I mean, there was a time when you looked at the rates for Black males and white males, and the disparity was quite wide. I mean, and then over time, the trend has gone somewhat like this, so that now we see, particularly in the period estimated on the slide, where Black males started to commit suicide at similar rates as white males. And there's been a lot of discussion about that period in our history and how we might understand it. But even absent that bump in depression and suicide among Black males, we know that men who have higher rates of depression are also likely to have other diseases that are preventable and that they are more likely to die from. We know that depressed Black men, for example, are less likely to have a usual source of care or to get preventive health screenings. And I've looked at this finding across nationally representative data, across community data. We find the same connection. So there's something important beyond just understanding the emotional status of Black males, but something that has even larger, greater public health and population health significance that we need to understand. And more specifically, we know that Black males have distinct risk factors for suicide and depression that are linked to psychosocial aspects of race. And one in particular is everyday racism. And I want to define that for the group. How many people have heard the term everyday racism used? Okay. Tell me what your definition, and it doesn't have to be perfect. Yeah, I just want to get a sense from you how you might define everyday racism. How would you know it if it showed up?
It's like kind of just differences and like that people experience, I guess.
Mm-hmm. And differences in how?
Like everyday life, like where they go to school, where they live, like everything that they experience.
Yep, it can show up as a structural difference, right? Differences in housing, access to resources, and employment, absolutely. Other thoughts about everyday racism, how it shows up, how you would know it?
When you enter a department store and then the security or somebody just right in your face can help you, but they're not really interested in helping you, but somehow they feel that they have to be right in front of your face.
Absolutely. Classic example, textbook, perfect. So when I talk about everyday racism, I am talking about those everyday social transactions that emerge from the dynamics of racism that we all know and can feel but are hard to define, and they're somewhat nebulous in their appearance. In fact, we talk about everyday racism as brief, subtle, ambiguous, commonplace, verbal or behavioral indignities that are enacted upon individuals based on their race. And we refer to these as microaggressions. And microaggressions are not just defined in terms of the scope, like micro as being small, but just because of the brevity of them and the fleeting nature of them, and actually the lack of opportunity to confront someone about those experiences. And we talk a lot about this as psychologists, about the psychological implications of ruminating about an experience. Now, me walking in a store, I'm dressed a little bit like I am now, fancy, and someone asked me if I could help them find the tank I've never had tank. I don't know. I mean, I don't even know where to find it. I have no idea. I was not wearing the uniform of the day, which was khaki pants and a blue top. That's the uniform for the store. But this person thought that I was there to serve and work, and so they asked me to help them find the tank. And so I walked out of the store, and I spent, I'm not even kidding you, someone who reads about this work and who does this work spent probably an hour on the phone with different people in my life talking about, well, do you think that was about race? What do you think that was about? Oh, I should have said something. And all of that sort of ambiguity and mental gymnastics that you do at following those exposures actually have psychological implications. And I think we could all tell those stories, you know. So we try to understand these dynamics among black males because we know that they are more likely to report everyday racism experiences than black women. And we don't know why. And I have some thoughts, and I would love to hear yours. But I think it has to do with the way that everyday racism is enacted. Like, it polices your physical presence, right? And so you think about black males and the stereotypic notions that follow this community, that when they show up in a space, people are aware and on alert in ways that they may not be as when black women are present. Now, I'm not saying that we don't experience a fair amount of that, as I have just illustrated in my story, but I think it shows up in slightly different ways and has real serious implications for black male mental health. And when we actually ask black men, you know, themselves to tell us about their experiences with racism, this is what they tell us. This is a quote from a recent publication, and they, you know, tell us that there is a sort of imposed silence that is associated with racism. One man in particular said that racism has forced him to sit on top of his pain, to feel that there are few outlets to share his feelings or frustration with the system, and that doing so not only makes him feel weak and vulnerable, so threatens his masculinity, but also puts him at risk for further insult and injury because people don't take those reports very seriously. And I think that this suffering and silence has critical implications for the male mental health paradox that I described, and chief implications for how we think about population health for this community. So I want to tell you just one of the things that we also know about this is that younger black males report also more everyday racism. And remember the question I asked earlier about whether or not this varies by age. There is something developmental in nature about the exposure to everyday racism. It's the way it shows up, the way men grapple with it, and the implications for their mental health. And I think given and I don't even want to say state of our young black males, because I think we're actually hemorrhaging a lot of the talent there. And I don't think that we're fully utilizing the resources that are present in this cohort of young men. But I will say that that group of men tend to struggle a lot more with discrimination, how to manage your emotions around it, and the subsequent mental health impacts are pretty pronounced. So it's something I think that we have to think about in our conversation together. So I'm going to skip through this and just tell you a little bit about what we found in this study on black men and depression, because I think it has implications for the dialogue that I hope to have with you following this presentation. So one of the things that we found in the study, we were interested in understanding whether or not the association between discrimination or everyday racism and depression would be stronger among men who believe that they should shut down their emotion. Because we wanted to understand, how can we intervene, how can we create a safe space for black males to talk about their experiences with racism, and if we did that, would it help? Like, is that the thing that's actually driving the associations between discrimination and depression for this group? And we actually did find that. And this slide really just shows you, it's just a graphical representation of what we found. So you'll see on this axis we have the depression scores, right? And then here we just have the reports of everyday racism. And what we wanted to see is whether or not the relationship between these two factors would be more pronounced among men who said, I should shut down my emotions a whole lot, and those who said, you know, real men don't have to really shut down their emotions in order to demonstrate their masculinity. And what we found was this. So I'm going to show you, do this slowly, because these are often hard for me to get unless I can see them visually. So this is a line for men who said, it's not that important for me to shut down my emotions when I experience stress, right? So you see it's pretty flat, the relationship still in a positive direction, so more discrimination caused, not caused, but was associated with more depressive symptoms. And men who believe that they should endorse that a whole lot, you see how significantly associated this line, the blue line, the higher association between discrimination and depressive symptoms. So what this told us was that there is something about not just experiencing discrimination that is associated with depression, but experiencing it and believing that you shouldn't tell anyone about it, not so good for Black male health. And I think that that has implications for other subsequent negative health behavior engagement. So if you think about our incarceration rates, if you think about violence engagement, substance abuse engagement, a primary predictor of that kind of engagement are strategies that people use to deal with their emotions. And if Black males feel that they have to shut down emotion in response to these things, they're probably more likely to engage in those kinds of behaviors as a way to cope. So we want to prevent a broader repertoire of coping options for Black males in ways that will promote their health and not lead them down a negative path. So I think I'm probably at time. So I'm not going to talk a lot about my year. I'll do a real quick photo journal, through my year in the White House, because what I also learned in this year of leadership was how to catalyze my own emotions, and particularly how to catalyze anger in a way that would actually help me to be a more effective leader. And so the quote that you see on the left side of the slide is actually something from my journal. In my year as a White House Fellow, they encouraged us to journal every day about our experiences. Now, I can't say that I did it every day, but I did a significant amount of days, and it wasn't until I was invited back for this talk that I actually went back to that journal to read some of the things I wrote about. And one of the things that I wrote on a day when I got really angry about something that was supposed to happen for our returning servicemen and women and didn't, was that I realized I was trying to stuff down my own emotion, and that the cool pose that I was trying to encourage Black males not to exhibit, I was also doing that in an environment as a strategy to cope with those experiences. And what I learned about myself and about leadership in that moment was that I needed to strive to honor and detect and put my anger to work in the service of other people's lives and in humanity, in the service of greater humanity, but that visionary leaders are not only defined by what they think, but how they feel. And so anger, as I'm always saying in talks I give about Black male health, mental health in particular, is a legitimate and normative response to social injustice. So if you find yourself getting angry, think about what kind of anger it must have taken for the civil rights movement to go forward. What kind of anger it takes to put in motion any kind of protest practice. Like, anger is legitimate. And in fact, as a psychologist, when someone isn't angry when they should be, I'm thinking maybe we should be talking about some treatment. So I think that we need to anger's gotten a bad rap. And I learned that in my year, in my leadership fellowship, that I needed to learn how to catalyze it as an opportunity to create structural change. And I think also anger is an intuitive reminder to us to resist intellectual and moral complacency. Like, if you're going to do this work, you have to go in. And you have to be prepared for experiences that will put you in a position to be reactive and push back on that and become more responsive in your approach to dealing with those instances. And so these are just pictures from some of the experiences in the question and answer period. I'm happy to talk about some of the things that I experienced, but I learned to listen more than talk, because when you're in a room with the Secretary of Defense and men with a lot of brass on their shoulders and you only have a cute pendant, you don't say much because you know that you're there to learn. But then you learn how, from watching them, to respond decisively. When you're given the moment to speak, then you learn how to develop a more intuitive, holistic response. So I learned a lot about listening. In fact, my first 3 months there, I don't think I got to speak a word, because you just didn't do that when you were with the Secretary. But I also learned, after things did pick up, to claim my seat at the table. And the one thing I want to encourage, especially younger people in the room to do, is to, when you get a seat at the leadership table, claim it. Because you are supposed to be there. There is no serendipity. My grandfather passing, my exposure to meta-narratives about racism and structural inequality from my mother's hair braiding sessions. None of that was accidental. All of those were preparing me to take my place at this table of leadership, but I had no idea it was even going to be prepared for me. So just be prepared to step into that and be ready to claim it. And wherever and whenever you enter, enter courageously. Now, I did some stuff this year that I never would. All of my friends know I'm really afraid of heights. Like tears, the Oprah ugly cry, when I'm put in any situation where I have to confront a height difference. And I was on numerous military vehicles, let's just say, flying in spaces that I never thought I would be, and experiencing things I never thought I would. But one of the things I realized is that I was, again, supposed to be there, and that I needed to do it to stand up and take on those experiences with courage. And I just want to encourage you to do the same. And the other is that when a leadership window opens, be prepared and willing to go through it. Because I did not plan to apply for this fellowship. In fact, I applied at the very last minute because I thought, who am I to like go work for the White House and I won't get selected. In fact, someone told me that you will not get selected. So you should probably try, but just hold back your enthusiasm because it's very competitive. So you never know where you're going to end up. And I was just so grateful that I had the opportunity to be there and to serve our country in this way, and really became like the most patriotic I've ever been in my whole life. It's really hard to be patriotic when you grow up in poverty because you don't see a lot of the stuff that the American dream is supposed to offer. But this experience taught me that life can offer all kinds of opportunities to serve and lead. And I guess the last thing I want to say is that the work that we're talking about doing together, the social justice work, is not work that can be done in solo. This is collective work. And so even as I talk about all these experiences and all these things I've learned, I still remember that I am just one person, and that I bring to that process a level of understanding, but I'm also getting something also. And that I'm not there to be a missionary. I'm not the savior of black males. I'm there to help aid and assist and uplift and perhaps make a difference on some small scale. So I encourage you to keep that level of humility and grace in your work, even as you learn and become elevated in your careers. I want to thank you for listening and for bearing with us through the technical difficulties, but I also want to thank some people who have really helped me do this work, because again, this is collective work. These are the members of my research lab at UNC, both past and present. All the funders, thank you, NIH. Thanks, shout out to NIH for funding my work, and the Robert Wood Johnson Foundation, who trained me and continues to fund my work. But also, I want to thank John Jay College of Criminal Justice colleagues here who helped shape my career. I don't want to say too much here because I really will get teary-eyed, but all of these folks on the slide in some ways have touched my life, but none more, I think, so than Dr. Janet Domingo, who not only inspired me by her own empathic leadership style, but also believed in me and took me in and helped me to become the scholar that I am today, and encouraged me along the way in moments when things got real tough. So I'm forever grateful for that, and I would not be here if it weren't for her. And then all the other people on the slide who taught me about form and style and the life of the mind, and Jama, who taught me the term meta-narrative, which I use probably once a week, nerd admission. Number one. And then, of course, Dr. Janice Johnson-Diaz, my dear, dear friend and colleague, and the McNair program staff. So, and all of you for bearing with us and staying around. So I'm happy to answer questions. I'm just going to put up my contact information while we're doing the question and answer period. And in case we don't get to your question today, please email me. I am responsive to those, and I would love to hear from you about your thoughts about black male health and about this work, and even if you're contemplating career path decisions. So thank you. The first question is always the hardest.
Okay.
Sure.
I never have anything to say. Profound presentation. It's upsetting. It's depressing. That's not even begin to touch on it. When you speak about racism and the effect on black men, I think, well, I can definitely attest to that. Those moments, what did you call them? What did you call the moments?
Microaggressions.
Microaggressions, perfect. Absolutely perfect. And the frustration that you touch on, there's nowhere to put it. When I've had conversations with other African American men about it, they're like, you don't even have to describe it. What you were saying about shopping, everyone, and I'm sure anyone who has any melanin whatsoever in their body in this room, the second you started to speak, every single person was like, yeah, because it happens every day. When you speak about the disparity in the way that African American men access health care, the patient experience, it's a nightmare. I had one experience that I had with my primary care physician. He's an African gentleman, and there was one visit where he cut me off at every moment when I tried to describe what was going on for me. And at the end of it, he told me what I was feeling. And I said, you know, somehow, doctor, I don't think that's the way it's supposed to work. And he didn't know what I was talking about. I said, you haven't listened to a single bit of my description of what I'm experiencing. And he said, well, you know, I've been doing this a long time, young man. And I said, you, sir, are not the patient.